So what would first happen is that you would log on to the CWP, that's what we call this, and then you'd select a patient. And I've just disguised them all now because this is obviously an open session, but you just put the Christie number in or the NHS number in. So if we put that in, you'd get this, which is the menu screen for the patient, and you just click Refer to MDT, which is here. And then I'll just take you through it. You say this is a gynae MDT. It knows who I am, and because I'm a consultant, it's saying I'm a consultant, but obviously it wouldn't say that if you weren't a consultant, but if it was some other hospital, you'd say no, and then you start typing in the name of the consultant and it fills it in for you. So you don't have to do it yourself, all the name, and which hospital, and forgive me if I put the wrong hospital for this. Then you can select which meeting date you want it to be, or you can just default it to standard. And if you're defaulting it, you don't have to put any date in. You only have to put a date in if you want a date. Then the most important thing is you pick which cancer site it is. So obviously there's endometrium and cervix and vagina and PPC, but if you don't know and it's presumed, you can pick that too. So you can say it's presumed ovarian if you want. You can also say that it's a non-gynecological primary site. So for those patients who are referred to us, say, with breast cancer, who have an ovarian mass, you can click there. So if we, just for the sake of argument, we click ovary, because that seems to be the commonest one. And then again, the next thing is you say what it is. So is this a diagnosis and staging thing? Is this one of those ovaries that's a cyst and we don't know what it is? Or is it following treatment? So again, we'll do the simple one first. This is diagnosis and staging, and you put some details in that you do now. You probably put more in than that, but that will do for now. And you say, well, what we want is just radiology in this sense, because if we're going to be accurate. Actually, no, we'll do radiology in PATH because the woman had a biopsy set. So you do what radiology, so you do CT scan. This was from Wigan, or wherever I've just said that patient was from. Bolton, did I say? Bolton. You put the date in if you want, and the same for the PATH as well, if you like. Again, it's a biopsy, and again, it was done at Bolton. And then you can just submit the patient. Submit the patient. And this then takes you immediately to an ovarian MDT site. So you can see that most of the stuff you've put in has been pulled through already, so you don't have to put it in again. But then it just asks you some specific questions about that patient that are important to the outcome. And it means you don't have to put them in the things you've typed if you don't want. You can just put them here. So we say, well, a CA125 is 20, whatever it is, or 26. This is really important because it gives us an idea of how long the patient's been ill for before they present, which is one of the big reasons that we think that our outcomes are so poor. You click on the calendar, and you can either put a specific date, which seems unlikely that they'd know that, or you can just say, I don't know, sometime in June. You see, you can, for example, that. Then you say what the performance status is. Again, this is really, really important. You do this now, but this just helps you because you just click on the one that it says. So you just read what it says, and then you click the one that's most likely, well, the one that fits the patient. This patient already has forms entered because she's a test patient, so it's already loaded this from the past, and this will always happen with all these patients. Once you've put them in once, they stay in forever, their comorbidities. So you don't have to put them in again and again. But if you want to change them, or you're putting them in from scratch, you click on that field, and then you just say what the patient is. So my patients all have hypertension, there's a list here, and they all have diabetes and they're on metformin. It looks very big and busy, that form, but you get used to it very, very quickly. Lots of our nurses use it without problems, even though at the beginning they thought it looked quite difficult. That list is only about specific things that are relevant to cancer outcomes, and I know that some people feel uncomfortable in leaving things out. So as an optimal thing, there's another table to put things in that aren't related to cancer outcomes, but you might wish to record. So for example, lots of people have raised cholesterol and this patient maybe has multiple sclerosis, and you can add things like that as well if you want, but you don't have to. This next bit is basically because we've said that the patient doesn't have a Christie consultant, what we want to know is, can the patient have an appointment sent to them directly from the MDT? i.e., has it been raised with the patient? The safest thing to put is no. The safest thing to put is no, but if you know that the patient's expecting a referral to somebody from the Christie, you can put yes, it just will speed up the process, that's all. You can see the clinical details came through from where I typed them before, and you just say whether the patient's got a key worker or not, and again, these have been pre-filled, so you just start typing a name that actually exists, so it's quite quick. And then you submit it, and then you finish, okay? If you want, it's gone. As soon as that's gone, it's been received by the Christie, you don't have to check it. If you want to check it, you can go up into lists up here to MDT lists and click on the, and you see she's here at the top, this patient, so she's already there. In the MDT, what will happen is they will have this list, but just the gynae list, so it will be one big list, and in the MDT they will then click on the outcomes, it reopens that form, and we add the outcomes from the MDT. Does that make sense? But your bit is the bit we've done so far. I can take you to another one, a slightly more complicated example. We'll do a different patient. So again, same thing, go into the patient, refer to the MDT, same thing, gynae. We'll say it is my patient now because it's easier. And it's going from the Christie, can be standard. And this patient is an endometrial cancer patient, and she's had her surgery. This is immediate post the surgery. So we click on management following the surgery, and you can just put post-surgery here if you want. And we now just want the path, obviously, because it's post-surgery. Put the section done at the Christie. Submit it. No, I always forget that bit. Submit it. This takes you to the endometrial form now, which is different to the other form. It's done exactly before, and you say, well, it's following primary surgery, because that's important, because you need a stage following primary surgery. But if they had loads of neoadjuvant treatments first, you wouldn't. And you just say which surgery they've had. So you say, oh, they had an open hysterectomy, and they had a bilateral oophorectomy, and they had a pelvic lymph node sampling. Or you can say they just had THBSO, whatever. What the date of surgery was. Again, what the performance status is, because that's what is yours. These came through from the first time they were discussed. And again, I'll make sure the key worker comes through as well. And again, submit. So, see, if I did that without talking, it would be, we did them in clinic yesterday. It takes about a minute, that's all, to submit the patient from beginning to end. Does anybody have any questions? Oh. Does anybody have any questions?
No, I don't have any questions. I think it looks quite simple to complete, really, and it should save time. It certainly will save time.
Good. I mean, like I said, we did it in comparison to what you had to do before. I think what happens is you get used to it. So the first time you write lots in the boxes, but after a while you realise, well, I'm going to add the CA125 later, and I'm going to write what operation they've had later. So I might as well just put post-op here, because I'm going to fill the rest in later, if that makes sense.
Yeah.
And we open that same form in the meeting. We fill in the bottom bit, which is the histology post-op. We outcome the meeting, then it's finished, and you can see the outcome immediately as well. So if you were then in clinic the next day, you could open this in clinic the next day and see the outcome if you'd forgotten it from the meeting.
Right, okay. The only issue I have is if I'm not aware of the patient being sent to the MDT, is there any way that when a submission is sent, that an email maybe ought to be automatically generated to the MDT coordinator or the CNS? Would that work?
It would be tricky. The only way you can be on the MDT is if you fill in one of these forms, though. So who else will be doing them?
Well, it would be the referring consultant, which we're going to be changing at Wigan, because normally I would complete all the forms, but I am going to be asking whoever's referring now to complete this form. But I wouldn't automatically be aware that the patient's been listed, if that makes sense.
Karen, it's James.
Hi, James.
Hi. I know we had this conversation on Friday, but
Yeah.
there's been a following that meeting on Friday. I brought it back here. We've had a few more discussions, and we probably will have a little change around that process, where there will be one point of referral, so the patient gets registered at Christie on the CWP, so then you can complete it. So there'll be a point at which somebody will be sending the details into the Christie to put them on the CWP.
Okay, okay.
So that's the point at which you can pinch and count the people out, count the referrers out.
Yeah,
Right.
I think it would.
I'll explain it to you after the meeting.
Okay, no problem.
Yes. And so, but at the moment, I don't think we'd be in a position to give all your clinicians access to this, which is why we're going through the CNSs to put these patients on. And it is so simple. I think it's probably more efficient for you to do it, especially if that's what you do at the moment. But you don't have to do it in the long-winded way you do it at the moment. So you'd know you put them on.
Okay,
and
okay.
allows you to have access to all the data.
Right, okay, fair enough.
But I'll give you a ring sometime today or tomorrow to explain it.
Okay, that's fine, James, no problem.
Are there any other questions?
Okay, all right.
Good. I'm not sure what we're doing.
Right, that's fine. Thank you. We'll send the link of this recording to everybody, and then you can circulate it amongst your team and colleagues so they can see how easy and straightforward it is. And of course, any questions, just email me, and we'll take them up with the team here. All right. Thank you, everybody.
Okay. Thank
you.
you.
Bye.
Bye.
Bye.